you guys for joining us today. We're going to be talking about just outpatient measures, talking about the specifications. Robin Carlson, our great contact and great speaker, will be talking about, what counts, what goes into the measures, things to consider when we look at our population. So let me go ahead and share my screen. I had a couple of things I wanted to share early on. Now, Robin, is it just my PowerPoint by chance that you see?
Yes. Mm-hmm.
Okay, good. So I just have a few slides of things for us to talk about. So just to reiterate what the outpatient measures are today, I know we've had, over the past couple of years, we've had a lot of changes, a lot of measures coming out, some being added in. But today, if we look at the measures, these are the outpatient measures that are in here today, and there's not a date scheduled for them to be removed at this time. So we have still our AMI and chest pain measures, our OP2 and OP3, and then we have 2 emergency department type measures. Outpatient 18, which is our median time from ED arrival and 2 ED departure for our discharged ED patients, the ones that do not become our inpatients. And then outpatient 22, it's the number of left without being seen. And so that one is submitted just once per year. It's May 15th. So for example, May 15th, 2020, we'll be submitting by that deadline calendar year 2019. And it's our total ED encounters and then our number who left without being seen or left without being evaluated by a medical professional. So I have some of our state data, and I understand it's probably a little bit blurry. I tried to blow it up so we could see it well. Just statewide, what our measures look like. The first 2 are our AMI measures, the OP2 and OP3. I think almost everyone on the call, I've been to your facility and probably talked with you about these. These 2 measures, they're tough. We don't see a lot of patients. We don't have a lot of patients reported statewide for our critical access hospitals. So you can see we had 23 critical access hospitals report these 2 measures in first quarter 2019. We had 10 patients for OP2 and then 8 patients for OP3. It's a very small sample size that we see statewide for those 2 measures. Then OP18, this is one that we definitely, you see more of. We have more hospitals reporting this measure. We have 28. We'd like to get 40 reporting this. But this is our, the ones who come to our ED and then they do not become our inpatients. So what is the median time for those folks? And so statewide, first quarter, we were looking at 2,398 patients. Our average statewide is 90 minutes. And you can see, this is similar to the Eurotelegen reports that you get. The average across the country for all critical access hospitals is 110 minutes. So we're 20 minutes on average better than that. The number to strive for, though, is our 81 minutes. So we're getting there. We're getting close. Then outpatient 22, again, that's the one that's just reported once per year. Over the past few years, and it's been 1%. And so it's 1% of 125,052 patients for calendar year 18. We had 29 hospitals this past May submit this number. So just something to be thinking about kind of when we start talking more about the specifications. So just some upcoming reporting reminders. The fourth quarter 2019 emergency department transfer communication data, we will open that link up on January 2nd when we come back from Christmas break. It'll be due by January 31st. I know you've seen our emails and our correspondence about the new EDTC specifications. Those will not go in effect until our first quarter 2020 transfers. So in January, when we start reporting the fourth quarter 2019 EDTC data, it's the previous specifications, the ones we've been using all along. Now, while we're talking about the new EDTC specifications, if you recall, in September, Robin, she did a great job of presenting what the specifications are. Nothing on that webinar has changed. So that webinar is still a good resource. However, there's a couple webinars scheduled, one tomorrow and then one in January, to talk about the new specifications or just some of the revisions that have been made. And I understand there will be a recording made of that webinar, and we'll be sure and send the link out to that once that's available. But again, those specifications will not affect transfers until the January 2020. Other upcoming deadlines are third quarter 2019 outpatient measures will be due February 1st, 2020, and then our one inpatient measure, ED2, will be due on February 15th. After that day, there's just one more submission for that ED2 measure. So that is all I have, and I'm going to turn it over to Robin. If you've not been on one of our webinars previously, Robin Carlson is our resource that we talk about all the time that is so awesome and so great with Stratus Health. You know, when you send us emails with questions of this, what would you do in this situation, or does this count? Robin's generally the person we reach out to. And so, Robin, I will turn it over to you.
Okay, thanks everyone. I'm going to share my screen, and that's not what I wanted. So, okay, can you see the Qualitynet page now? Anybody? Yes. Okay. Yep. So I know I'm talking about outpatients today, but I wanted to start with this page because this is new. And maybe you guys have already seen what it looks like, but in case you haven't been over here, this is what the new main page for Qualitynet looks like. So this is the www.qualitynet.org main page site. It looks like this now. I think it really looks a lot cleaner, but if you were used to the old site, it might be kind of hard to find a few things. So just like quickly, here's where, if you're logging into the secure portal, there's where you would do that. And that's not really changed a lot once you log in there. But we're going to do hospitals outpatient. So what you want to do is click on the hospitals outpatient. And now you've got like several different options, but right away it brings you up to the specifications manuals. If you were looking for CART, you would go under the data management. So that's where CART is, if you're wondering. And then there'll be the boxes about, well, let me try this for you. Okay, so there's going to be your CART tool. So there's where you'll get your next versions and whatever version you have to have. And then for anybody who would use that paper tool, I don't know if they do or not, but that's under abstraction resources. So again, if you're looking for the CART stuff, it's under either hospitals, inpatient or outpatient. It would be under the data management, and then there's your CART tool. So let me go back. Okay, so we want to look at the specs manual. I'm just going to view all. I don't want to download anything right now, so just view all specifications manuals. It will always bring you up to the most recent version. So here's your version that you're going to use for starting with January 1, 2020 encounters. So we're not there yet, okay? So we're going to be using, but just a reminder, okay, when you get ready to start your abstraction for 1/1/20, you want to make sure you look at these release notes. That's going to tell you what's different in this manual from the last version, the version for the 2019. Okay, so we want that version. And always set up the same way. Here's your information about downloading. There were your release notes for this version. But what I want to do is show you, I want to show you the populations for these different measure sets. Now, I know when on the slide that Laura had where she said AMI chest pain, really there's no more chest pain measures. Chest pain, the last chest pain measure was OP5 and that's gone. So really we're not doing any chest pain measurement anymore. It's just really the AMI measure set. And you'll have to forgive me, I'm finding this stuff the best way I can, so sorry about that. But let me say this, and oh, hey, I am open. If anybody has any questions at any time, just interrupt me. Or Laura, if you're seeing questions, just let me know. But this is the AMI measure set, okay? Now, this is OP2 and OP3. This fits in here. So this is what you look for, okay? There's no saying I don't do AMI cases. I'm not going to do these. You know, hopefully there isn't. But you just, the first thing you do, and I apologize if you've heard me say this before, but I can't say it enough. the first thing when you're abstracting is you look for the population, okay? So I've got my AMI measures, that's OP2 and 3. You'll see where 5 is gone now, okay? But this was the manual. If you're never unsure of which manual you're looking at for which encounter dates, it's always on the bottom. So this is the manual that we use for instructions for all of 2019, okay? And so that's why you have to have information about like this one where it's yellowed out, because this ended after Q1, but they didn't redo the whole manual. Okay, so we're going to do OP2 and 3. How do we know which records to do? Okay, you need to know the population. And this again, it's under that AMI measure set in the specs manual. Each measure set has its own section, and you scroll down to that page where it comes to the population. Okay, so these are the data elements. Okay, you'll get to that when you're answering questions, but this is the important part. Patients seen in the emergency department, and they have to have an E&M code. That's how, for determining records or patients seen in the ED, an E&M code is how they choose to determine that. They're included in OP2 through OP3, AMI hospital outpatient population, and are eligible to be sampled. Well, I don't think anybody has enough to be sampled. You don't have to worry about that. You're going to do all of the cases that you find that meet these 3 requirements: are discharged or transferred to a short-term general hospital for inpatient care or to a federal healthcare facility. Okay, in terms that we understand, what this means is they were discharged or transferred to another acute care facility or to like a federal healthcare facility, okay? Another hospital. They were transferred to another acute care hospital. They were 18 years of age or older, and they have to have an ICD-10 principal diagnosis code for AMI defined in Appendix A on OP Table 1.1. And I want to find this, so, because I want to show you, so I'm terrible about this, so I apologize. I want to find, that's where I am. Okay, great. Okay, again, this is that one page where we found the manual. How you find your code lists down here in the appendices. Okay, now you got to be careful here because we've got 2 different code lists. Okay, this is for Q1 through Q3, which is going to be due in February. This is for Q4. Now, the reason they have a different code list here is because in October, is when the ICD-10, when they change codes, there's a potential of code changes. So that's why they had to make another code list for Q4. But right now we're in this quarter. So if I look at the PDF, okay, so these are our table of contents, these are our appendix, these are our codes, okay? Here's your E&M codes, okay? I know you can't get them from looking at a chart, but however it works in your hospital for pulling the records that you need to do, it's the E&M codes. But here's your table 1. These are your list of AMI diagnosis codes. So anybody who's seen in your ED has one of these codes as the principal diagnosis code. So not the not differential or not, I don't think any of these would ever be secondary, but we're looking for the principal diagnosis code at discharge. Okay, if they have one of these, they're included in the population. Okay. So that's your first thing. You know, you want to run a report by the codes. Let me get back. All right. Okay, so they met the code. They met the code, they were discharged, transferred to another acute care facility, and they were on the age. That's your population, okay? Those are the records that you abstract, okay? You don't worry about anything else right now. This is your population. This is what you enter into CART or whatever tool, okay? Patients that meet these 3 requirements. it's how you enter the data into CART, how you answer those data element questions. That's what determines whether that case maybe passes the measure or fails the measure, or you know, that's what gives you like a median time when you're answering the time questions. Okay, that all happens after you enter the data element questions. Okay, as long as you've got patients that meet these requirements, you enter those cases. Now, because this is AMI, maybe you don't have any. A lot of, some critical access hospitals don't have anybody that meets that requirement. They don't have anybody who has that principal diagnosis code. I would say in that case, in this case, it's not unusual. You could potentially have a 0. Okay, and that's where if you don't have any cases that meet this, this is where we ask you to fill out that population and sampling grid and put a 0. And that way we would know, hey, for the quarter they looked, had no patients that met these requirements. If you don't fill out population and sampling, and you don't put a 0, and you have no cases that meet this, those reports that Laura showed you at the beginning, they would have an NA there instead of a value, because there's no data in the warehouse. I'm not an algorithm person myself, but if you wanted to understand the flow, hey, more power to you. But here, this one, OP2, fibrinolytic therapy received within 30 minutes of ED arrival. This might be one where you would have patients that meet that requirement, okay, they had that principal diagnosis code, but maybe they never received fibrinolytic therapy. Okay, so you still have cases to enter. You don't pull anybody out because they didn't receive fibrinolytic therapy, or maybe you don't even give it where you are. That does not matter. Cases get entered that meet the population requirements. How you answer the data element questions might remove patients. So maybe you had 10 patients that met the AMI population requirements. And then when you're answering the data element questions, well, nobody got fibrinolytic therapy. So what that would show on your report is a DE, okay? That means you entered cases, they met the population requirement, but they didn't meet the specific measure requirement. And that's okay. There's nothing, that's not a wrong thing. Pardon me. So that, you know, if your reports show that, and you know that you don't do fibrinolytic therapy, then a DE, that's okay, all right? If you think you're getting a DE and maybe you're not sure why that should be, you always want to go back and look at how you answered the data element questions. Because again, that's making the determination that those patients aren't meeting the measure requirement. So questions around here are going to be like arrival time, fibrinolytic administration date and time, that kind of thing. Okay, but again, you don't decide to not do this measure set because you don't do fibrinolytics. That's not how this works, okay? Everything is, look at my population, oh yeah, I've got cases, then I enter. I don't think I need to read this to you. This just goes into, tells you what's included, what's excluded, the different data elements. If you guys have any questions on anything specific, just stop me again. Okay, and it is really important for us to note the zeros. You know, I think sometimes it's like, well, if I don't have any cases, what does it matter? But it's important for one thing, there's no minimum. If you only have one case, you want to record it. As Laura talked about, the number are low, but you want to show everything that you have. But a 0 is important to us to know too, because that's telling, if we see NAs, we don't really have any idea of how many cases. But if zeros are showing up, that lets FORHP, the Federal Office of Rural Health Policy, know that, you know, let's look at this. Are these really the measures, you know, that are relevant to you guys if nobody's having many in the population? Right now, we don't have a lot of say in what measures there are because CMS keeps removing them, but these are the ones that we have. Okay, so again, here's your information about, hello, can you hear me?
Yes, I can hear you.
Okay. So here's OP3, okay? Median time to transfer to another facility for acute coronary intervention. Don't worry about the A, B's, and C's. One is the overall rate, the reporting measure. You just enter your data elements for OP3. So this one, okay, same population as before, okay? But it's the data element questions, how you answer them will let you know like who fits in here. And it depends sometimes on how you answer it, different questions. There's more than one question. So like here, excluded populations, patients receiving fibrinolytic administration. So if you've got someone who's got fibrinolytics, well, they wouldn't even fit into this measure set, but that's okay, because you don't take anybody out. It's how you answer the data element questions. For this one, it depends on the initial ECG interpretation, how you answer that. You know, if all of your cases are answering a no, then those patients might not fit in this measure set. So that's okay. You know, you might end up having DE, or you might have a lower number than what you think you've entered. But again, it's how the data element questions get answered as to how those patients fit in the in the measure population, but not the measure set. Okay, I hope I'm not mixing up anybody. I don't mean to do that, but again, it's all about your population. Those are the ones you enter. How you answer these data element questions, that's like for CART, if you use the CART tool or whatever tool you use, these answers determine, okay, this patient would be included or would not be included. Anybody have any questions about OP2 and 3? Main thing to remember is these are not patients who would be admitted to your facility. Okay, these are just the ones that, again, with that discharge transfer to another acute care facility. Okay, if I don't, okay, I'm going to go on to, and again, so there are no chest pain measures anymore. Okay, so we're not pulling any chest pain population cases, just the AMI. And now we're going to the ED. Okay, there's only the two measures now, as Laura showed you. The one chart abstracted measure is OP18, median time from ED arrival to ED departure for discharged ED patients. So let's look for the population. Excuse me, okay? Population is identified using one data element in E&M code. So patients seen in your emergency department have that E&M code are included in the population. So doesn't matter what their principal diagnosis code is, doesn't matter what their age is. Again, the only thing is these would not be patients who are directly admitted, seen in the ED, and then directly admitted to your facility. Okay, these are patients who are either discharged elsewhere, transferred elsewhere, go home, whatever kind of discharge status there is. That doesn't matter either. It's just that they're not directly admitted. Okay, so this could be the one, like as Laura showed, where you have big numbers of patients. But pretty easy population. This is it. So everybody that meets this requirement, everybody seen in the ED, and wasn't directly admitted would be part of that population. Okay, so on your television reports, you should never have a 0. The only way you would ever have a 0 would be if you saw nobody in the ED for that quarter. And I would guess that would be highly unlikely. Or everybody that you saw in the ED was directly admitted. And again, I'm thinking that's probably really unlikely as well. So if your reports are showing you a 0, something's wrong. Okay, the yellow in here, I should have mentioned, if you guys are noticing yellow, what this means is this is different rationale than the last manual, than the manual that was in 18. And oftentimes, because there's so much, you know, lots of things going in healthcare, always newer studies coming out, newer information. So the reasons that for doing this measure, or the rationale behind CMS wanting us to collect this measure, they've updated. Okay. So any patients from your ED, patients, you would exclude patients who are expired, but again, those patients would be excluded once you started entering discharge status into CART or your tool. You don't pull those people out. That's why I have to be honest. I deal with people who abstract, and I'm really focused on the population, and I focus on the data elements. So I think this information on these measures themselves are important. I think it's good to know why what's the thought behind us wanting this information. And if you're getting questions, from your physicians or in your facility, well, why do we have to do this? Why are we doing this? Here's a good spot. This is the latest rationale of why they feel this information is important. And references, if you ever had to refer to anybody, or even if yourself, if you wanted to have a better idea of why you were doing these. I'm sorry, I'm scrolling around, but I think of things. Again, this is something where, again, you don't worry about A, B, C, and D. You're abstracting everybody that was seen in your ED from that population. A is the overall rate, so that would be everybody that fits in there. C are patients who have a psych or a mental diagnosis. The reason why those are excluded from the reporting measure, now, you don't exclude anything, okay? You're entering everybody that fits the population. When you enter the diagnosis, because everybody has a principle, and no matter what you're abstracting, any of these measures that it always asks you for the principal diagnosis code. But psych mental patients with their diagnosis codes, they often are in the ED for a longer period of time because, it's not always as clear as to where that patient should go, where we need to transfer, whatever. So they don't want to have your time be inflated because of those patients. So that's why they have, like, 18C is their own. Same thing kind of with transfer patients, certain transfer patients. Some of those get pulled out as well. You don't pull them out. How you answer the questions in your data entry tool will pull them out. And so then reporting measure would be the ones that would be removal some of these, so your times won't be look quite as long. Okay, so you don't ever have to worry. I get questions about that as, well, what's C and D and A? This is what they are, but again, when you're abstracting, that's irrelevant. You're answering the data element questions. Pretty much the questions are around times, departure time, arrival time, that kind of thing. So that's the measure, OP18. Quickly, I wanted to show you OP22, and everything that Laura told you about that was correct. It's the percent of patients who leave the emergency department without being evaluated by a physician, advanced practice nurse, or physician's assistant. So this isn't a chart abstracted measure, and there's no instructions on how you are to collect this measure. The thought process, I believe, kind of for there not to be any instructions, is that CMS believes that everybody should be tracking this in some way or the other, so they're not telling you how to track it. But what you need to answer, the couple of questions that is asked of you, is the total number of patients who presented to the ED. So your total number for the year, and as Laura said, now entry for 2020, which the due date has always been like May 15th, and we don't know that anything is changing, so we would be thinking, okay, it's going to be May 15th for data from the year of 2019. So in 2019, what was your total number of patients who presented to the ED? And then what was the total number of patients who left without being evaluated by the physician, APN, PA? The only thing it gives you a little bit, patients who presented to the ED, excuse me, I'm sorry, are those that signed in to be evaluated for emergency services. Okay, so I don't know how it might work in your facility, if there's some kind of a sign-in a sign-in sheet or, you know, the minute they come in, they're like, you know, they speak to someone, anybody who presents there to be treated. And then the definition of the, you know, it's a physician, APN, PA. They came to the ED, they signed in, and then they left before they were treated. Okay. Now this is not AMA patients, because AMA are patients who left against medical advice, and I don't think you would be leaving it. You shouldn't be coded as a discharge status of left against medical advice if you weren't seen by a physician or an APN or a PA. Okay. So those patients wouldn't count because they would have been seen by by a provider. So those are your measures. What I would like to do is, I apologize, it's probably gonna take, oh great, okay. I want to talk a little bit, unless anybody has any questions right now, I want us to talk a little bit about the data elements. And the data elements are in the data dictionary. Hopefully I'm not showing you anything that maybe you haven't seen before, but again, please stop me. This is the data dictionary part of the specs manual, and these are all the data elements. So this gives you the instructions on how to record the data elements. I think there's some in here that you're not going to use if you don't do like the stroke measure or whatever, but I think some of the ones that can be kind of tricky, like if we look at this one, transfer for acute coronary intervention. Was there documentation the patient was transferred from this facility's emergency department to another facility for acute coronary intervention? Okay, you've got yes, there was documentation the patient was transferred specifically for acute coronary intervention. There was documentation the patient was admitted to observation status prior to transfer, so then you'd answer this as a 2. And then there was documentation the patient was transferred for reasons other than acute or coronary intervention, or the specific reason for transfer was unable to be determined. Now, a lot of people get this wrong that I've looked at, because this has to say the select value 1, the select transfer for acute coronary intervention. You have to see that that patient was transferred for percutaneous coronary intervention. They're transferred for an angioplasty. They're going to the cardiac cath lab, okay? It can't just be they're being transferred to a general hospital, because I know that's where we always send our heart patients, okay? This is asking for a specific reason for coronary intervention, okay? Now, maybe you don't know once they get there, they might not have it. Well, you don't know that. We don't know what happens once they go there. But we're looking for some kind of, the thought is they're going for some kind of intervention, okay? It isn't just, you know, we're sending them to cardiology, okay? Has to be for one of these things to say yes, okay? Reason for transfer must be defined as some kind of intervention, okay? Transfer for cardiology consult, that isn't like, you know, or we don't have cardiology services here. That's not saying a specific intervention. So then you would use value 3 for this one. Sorry, I kind of got to scroll up for this to get back to the beginning of the, that's one I think that a lot of people maybe miss. I'll show you, I think dates, I think, are pretty clear. The only time you would really have to watch a date is if you were admitted to the ED, maybe, you know, maybe you're admitted close to 12 midnight, you know, and then your next date would be, that's where you would have it different. But dates, I think, are usually not issues. ED departure time. Okay, I think there's lots of instructions, okay? Because it seems like it should be clear, departing from the ED. I've noticed a couple things. If you're working off an EHR, I mean, the person only leaves the ED once, but I have seen records where there was like 3 different times that said patient left the ED. Well, no, that's wrong, because you can only really leave once. So it's kind of your responsibility as an abstractor then to find out, okay, which time, what are we looking for here? What are we really looking for here? And what we're looking for is the documented time the patient physically left the emergency department. So if you're looking through your EHR and you've got 3 different times that say ED departure time or discharge from the ED, you have to find out, okay, when did they physically leave? Which is the time here that they physically left? That's what you're looking for. Okay, and it will give you some examples of what's acceptable, or, you know, if you have this situation. Here's what to do if they go to outpatient observation status, okay? Oh, I think somebody had a question about that, but generally, when we're doing outpatient cases, okay, when we're doing OP2, OP3, OP18, if you're seen in the ED and you go to observation, and then you are transferred or discharged or whatever, you're outpatient. For this abstraction, you're outpatient unless you're made an acute care inpatient. So if you're seen in the ED and go to observation and then get discharged, you fit into outpatient measures, okay? If you were seen in the ED and you go to observation and then you're admitted, then you're not going to fit into outpatient measures. Then you would, that would fit into your ED inpatient measure set. So if you've got someone who is, if we're looking again, we were looking for that time, ED departure time. If the patient who's placed into observation, for patients who are placed into observation services, use the time of the physician APNPA order for observation for the ED departure time. So that's what you'd put for the ED departure time, is the time of the physician order for observation. So they kind of explain why the intent of this is to abstract the time the patient is no longer under the care of the ED. When a patient's placed into observation, their clinical workflow may vary from patients who are not placed into observation prior to departure from the ED. So the observation order may be used instead of the actual ED departure time. Okay, that's their explanation of why they want you to use that order time. Okay, gives you some ideas. Now, if you don't see ED discharge time, if you see departure time or release time, transport documented time, these would be acceptable, okay? These are places that they don't want you to really look, okay? Can't do report call, can't do discharge instruction time. You know, you could be given discharge instructions and still be sitting in the ED for a couple of hours before you leave, okay? So always remember this, you guys. Come back here. If you're not sure what's being asked for, in these instructions, I mean, you might have to dig a little bit for it, but again, this is what we're looking for. ED departure time is the time the patient left the emergency department. So as best as you can, again, if you've got several different spots in your EHR that's saying these words down here, okay, you want the one that is the most accurately saying, when did that patient, the one that's saying, when did that patient leave the ED? Any that I'm looking at here that anybody would like to talk about? I think initial ECG interpretation can be a difficult one. I think the best thing that I can say about this is that you really have, it's a step-by-step. Okay, that's why it's got methodology. Identify the ECG that you want to be looking at, tells you how to do it. Okay, what are we going to be looking for? We want assigned tracing. You're going to then determine if the phrases are inclusions or exclusions. If you don't have assigned tracing, or if you don't have an exclusion, then you can look at things other than that initial ECG interpretation. So you can look at physician documentation, if they're talking about the ECG in their provider note, you need to know what you're talking about. The first one, perform closest to arrival, but again, you have a step-by-step on how to do this. Tells you what's acceptable, what isn't acceptable. Okay, got a whole list of words that you're looking for. These are inclusions. These are ones we would say yes to ST segment elevation. This is when we would say no. If you see any of these words, it's a no. So this can be a difficult data element, and I've been doing this for as long as there has been abstracting, and I look at this if I'm looking at an ECG and trying to answer this question, because I don't remember all of these instructions. And don't worry about, there are times, because these are very specific instructions and we're looking for some very explicit wording, maybe you're having to say no, but it's not saying in any way that this person didn't have an AMI. Maybe you've got, well, you're looking at this case because they've got the principal diagnosis code that fits in that measure set. So, you know, don't be thinking, oh, I'm not putting yes, I've got to take that out or whatever. It's just how these instructions are set up, okay? We're not able to answer that question. Following these instructions, we're not able to answer that question as a yes. So this might get your patient maybe thrown out of measure 2 or out of measure 3, okay? But you enter that patient because it was part of the population. How you're answering these data element questions will determine whether, you know, that patient fits in that measure set, fits in that measure criteria for 2 or 3. Okay, and a lot of times we're putting no for this, and that might be why you're showing, you know, even though you think you've entered 10 AMI cases, maybe you're going to have none that show up in the reports that Laura was showing. Maybe you'll have a DE because nobody met it. Anybody have any questions about any of these data elements, or that's really the only outpatient measures that are left? Laura, anything that you want me to talk about, or again, does anybody have any questions?
Yeah, if we want to open up to questions, I think almost everyone's line is muted. So if you want to go in and manually unmute your line, or just type a question in the chat box, we can address them. Robin, through your abstracting for accuracy program, are there any things that you noticed that stand out that we're missing?
Yes, good question. And a lot of it is the issue that I mentioned about the times. You know, we talked about the ED departure time here, but even for the inpatient measures, anytime there seems to be a time, admission or discharge, anything around that, with EHRs, there seems to be several different times. And, you know, it's not really, shouldn't be a crapshoot as to what you pick, okay? You know, I don't, when I talked with people who did that, and I had to talk to them and say, hey, why did you pick this time over this time? You know, this one looked like, to me, like it was the most accurate, but these are your records, this is your facility. Who's entering this? Who's entering this one? Okay, then I would take them back and show them at the data element, this is what we're looking for. So if we're looking for, say example, the time that the patient physically left the ED, which one of these is it? And if you've got 3 different times and you have no idea which one is the time that the patient really physically left, that's when you put unable to determine, and you really don't want that, okay? You're getting nothing out of unable to determine. That's gonna throw your patient out of the measure set, and so you've done this for what? You know, that shouldn't be. Everybody should have these, you know, a discharge time. So that's a big issue. One of the issues was around acute coronary intervention. People would put yes when all the documentation said is that they were going to cardiology, or we don't have cardiac services, but nothing, no definite, you know, didn't say they were going for a cath. didn't say they were going for a possible PCI. Those are the big ones that I can think of around the times.
Okay, does anyone else have a question that you'd like to ask?
Oh, let me just show you guys something, if you don't mind. When we were talking about your ED population and how it was pretty much everybody seen in your ED, unless they were admitted, that's the one measure set where maybe you can sample, because you might have enough cases that meet the sampling criteria. So I'm still in the specs manual, that, you know, the page with the manual, but I'm in the population and sampling specification section. So this is where you could scroll down, and we're talking about OP18. So this is the sample size requirements for OP18. So unless, Laura, and I apologize if you had some kind of a requirement that about how many people should do, but because the numbers could be big enough, this is where you can maybe sample if you want to. You never have to sample. You can always do all of your cases. But if you were sampling, you would have to do at least this many for OP18. At least, if you have between 0 and 900 ED patients in that population, you have to do at least 63 for the quarter, 21 a month. Or if you have over 900, 901 or over, you have to do at least 96 for the quarter, or 32 a month. So they do give you an option. CMS has like that sample that you can do if you're seeing this many number of patients. Okay, you would never, I don't think, ever meet the requirements for the AMI, so I don't even go over those. But this would be the case. This would be the sample size table for that one. So sorry, I just thought of that.
Oh no, thank you. Are there any? Does anyone have any questions that you'd like to pose? One thing that I'm glad that you mentioned was the outpatient 22. AMA is not. That's not the same as AMA, because we do get that question often about, I'll just pull AMA and put that in, and those are two different measures, or two different things to look at.
Right, because think about what they're trying to get at there. Are you having a problem with patients coming to the ED and they're having to wait too long to see a provider? Okay, that's what really that's trying to capture. To give you some assistance to see, okay, we might have a problem here if we've got, if we've got patients waiting for hours. Okay, patients who leave AMA, someone had to make that, a provider had to make that that designation that they left against medical advice. So that's not what you want there. Those are patients who are choosing to leave after they have seen a provider. So they don't fit into OP22.
All right, well, we have just a few minutes left if anyone would like to ask a question. If not, thank you, Robin, for taking your time to meet with us, to talk with us about outpatient measures. As you move forward, if you start abstracting for the next quarter and have any questions, please feel free to let us know. And then also abstracting for accuracy, Robin, is there an open enrollment period or?
Yep, that is anytime. Again, we really encourage people, and I'm glad that you asked that, because sometimes I think people, everybody's facility is so different, and everybody's tool is a little different, and everybody's EHR is a little different. But even if you are, maybe you yourself don't have to abstract, like go into the chart and pull up a lot of things. Maybe you have a situation where a lot of these things are downloaded for you, and maybe they're downloaded right into your tool or something. But again, if whoever ran that report, or whoever decided, okay, I'm going to pull from this this data field, if it's not the right one, your data might not be accurate. You should go in and check, because we had that situation too when I did abstraction for accuracy. I abstracted records, and then I worked with, I was talking to the abstractor, and I said, you know, how did you get this time? I'm not seeing this anywhere in here, and this isn't really what we're looking for. And she's like, well, I don't do that. That gets downloaded for me. Okay, but it's not right. I mean, when I looked at the chart, that was not the time I would put. So, okay, you didn't have to do it, but it's wrong. So, you know, your values aren't coming out correct then. You know, and a lot of times I know that you guys, all of this, you know, this report running and figuring out what records you had to do could have all been done before you even started there. And who knows who worked on that or didn't work on that, and maybe you didn't have any say in it. But if you're pulling records, you know, or if this is pulling from data fields that aren't what we wanted, then that needs to be corrected. So I had some records where people knew they had to go back and you know, what was being downloaded like into CART or into their tool to answer those data element questions weren't correct. So don't be thinking just because you don't maybe have to do much abstraction that you don't need to do the abstraction for accuracy. It's really checking to make sure that that your measure results are right. And you know, more and more these are going to be looked at. You know, F4HP is going to come out with like some, you know, performance standards and performance measures, and there might be less measures, but they're not being looked at any less. So you don't want to be the one to have your hospital looking bad on a measure set because you're not abstracting correctly or the correct data isn't getting in there. You know, let's figure it out. Let's try to figure out what it should be. So no, that's open like anytime. If anybody thinks that they're interested, there is that. I think always in the monthly we've got that information about that, how to sign up. So yeah, it's always out there. Thank you for promoting that.
Well, thank you. It's a great program. We've heard really great feedback from it. So real quick, does anyone have a question that you'd like to ask? All right. Well, Robin, thank you so much for talking with us, and I hope everyone has a great holiday season.